Continue. Hello everybody, and welcome to our first live digital lunchtime session here at SCW. I'm Fran Draper. I'm one of the senior project managers here, and I've been involved in the sharing of information across organisations and between systems for several years now. And this sharing is what we call interoperability, basically the sharing of electronic information. So a warm welcome to everyone. This is the first lunchtime webinar, first of this special week, where we today are going to be discussing the SCW interoperability story. And joining us for the session today, we're really lucky to have Shauna Mcmahon, who is our Director of Transformation Digital. Hello, Shauna.
Hello.
Also telling us about his experience of setting up and running a large interoperability program, we've got Peter Camberopoulos.
Hello.
One of the program managers for digital transformation. Hello, Peter.
Hi.
And we've got Jocelyn Palmer, who's an informatics consultant who runs the Connecting Care program. Hi, Joss.
Hi.
And finishing today's presentations, we've got GP Dr. Michael Taylor. He's head of the Homeless Service in Bristol, and he's also the Chief Clinical Information Officer for Connecting Care. And he's going to give us some real life examples of how sharing information can impact on the front line. Hello, Mike.
Hello.
So without further ado, I'd like to go through the housekeeping section now. And to remind you that you can ask questions live during the event. You have to use the Ask a. If you can't see the feature, you should click on the Show Q&A button at the top right of your screen. And if you want to, you can ask questions anonymously. So we've got moderators behind the scenes. They're going to publish out as many questions as possible. So please keep asking them. And if you see a question under the feature tab that you think is a good one, please do click to like it, and then we'll know that we're focusing on the right subjects to follow up. Any questions that we don't get to this afternoon, we will share answers later on the website. And also you can add subtitles to this live event if you need to by using your captions and setting buttons in the bottom right of your screen. And also you can join the conversation on social media about all the events this week, and we'd really like you to do that. Please use hashtag SCW Digital. So that's all the housekeeping, and now I'd like to hand you over to Shauna Mcmahon, Director of Transformation Digital. Thank you.
Thank you, Fran. And I'm so pleased to be here kicking off this fabulous week of what I'm calling digital deliciousness. And I'm really looking forward to kicking off this session and also participating in the sessions that are running all week. They're all really, really interesting. And interoperability is really a subject that's been a passion of mine for a long time. And all of you in this session, I'm sure, would agree that it is the unfettered exchange of information that is the key to leveraging the impact of digital solutions and what it can do in the delivery of healthcare. And it seems to me in the last, well, prior to COVID anyway, that 80% of the newsletter articles, the webinars, the presentations that I've attended or read focused on interoperability and being able to have one synchronized flow of data across systems. Some digital experts are actually now saying it's not a digital strategy that you need, it's a data strategy that actually has your interoperability roadmaps laid out. And I recently read some information from Nhs where they are stating now that measuring the performance of health ecosystems is there's 5 things that they look at. It's governance, workforce, predictive analytics, interoperability, and person-enabled health. So all of those organizations are emphasized. We look at Nhs, Chime, NHSX, our local digital health networks, all emphasizing system integration and interoperability. And in fact, I might be so bold to say it doesn't even seem to be about EHRs anymore, but it's all about the ability to move data across digital systems. And SCW has been a leader in supporting our clients with interoperability challenges. And I think early on it was Andy Kinnear, and maybe if I have it correct, having conversations with Aid Byrne in Southampton, who at the time were both strong advocates of the need for interoperability. And these conversations led Andy and a group of thought leaders to start the Connecting Care project that you'll hear about in this session. In addition, it's our recognition of the need to have interoperable systems where data is shared led us working with clients and partners to develop the Hampshire and Isle of Wight Care and Health Information Exchange. And shortly, Peter will share an overview of that journey and where we are today. And many of you will be aware that South Central West has been a leader with the Thames Valley LICRA, and as well Catherine Dampney doing her work with moving data to work on population health management. We have some of the most experienced and skilled solution architects in healthcare working at South Central West. Currently, they are in great demand with clients to develop their interoperability models. And that demand is just continuing to grow. Every week we're getting asked to help in the area of interoperability and doing modeling and roadmaps related to sharing of information. And we welcome that opportunity to work with our clients and partners to expand the interoperability, because we know that is how we will all deliver safe, quality care for our citizens. I'm sure you're going to find the session informative in terms of how far interoperability has advanced in our region, and that after the session we'll have a more in-depth understanding of the breadth and expertise of knowledge that the South Central West team has enabling the exchange of information across digital solutions. So with that, I'm going to turn it over to Peter, and he can share with you what he's been doing with the, his sharing of data. Thank you, everyone.
Well, thank you very much, Shauna. We can have the first slide. That's brilliant. So yes, Peter Camberopoulos, I run the Care and Health Information Exchange, which covers Hampshire and the Isle of Wight. Next slide. And I wanted to sort of expand on what Shauna was saying there. And try and bring this out to something that's a bit more real, something that's less about the IT, and something that's a bit more about a human being. So we called her Doris. This is a real case. It was admitted to one of our local A&E units by one of our users. So Doris is a very sick woman. She's got acute necrotizing fasciitis, and she needs urgent surgery in order to survive the next 48 hours. Doris has got a long-standing problem with overeating. That's the reason why she's got the fasciitis, she's had surgery twice before, so she's an expensive patient. But you know, more important than that, really, Doris is also a person. She's a grandmother. She's been recently bereaved. And really, what the question I want to try and put in your mind is kind of how many professionals need to be involved in Doris's care, and how many organisations need to be involved in Doris's care in order for her to be able to live a good life. So if we can have the next slide. So I've just picked out a few here. She's going to have the surgery in the top right-hand corner. That involves having also imaging and pathology. She's then got to go into a sort of post-operative recovery within the acute trust. I've lost access to my slides, and I'm going to just crack on. She's going to need post-operative care from a rather young, depressingly young-looking team of junior doctors. She's then going to go out, going to need treatment out in the community. She's going to need wound dressing out there. And then, of course, we've also got to address the overeating. So she's going to need to have some sort of psychological intervention. She's going to need dietary advice, and she's got to get up and be mobile. So she's probably going to need some sort of physio. I'm going to go on to the next slide. So in Hampshire, Isle of Wight, we instituted something called the Care and Health Information Exchange. I'm going to come back in a second to that. We cover about a population of about 2.1 million. It's around about 180 GP practices. That number keeps going up and down because, thank you, we can just stay on that one. And we cover four acute trusts, a couple of community trusts, a couple of ISTCs. Importantly, we've got 4 social service departments as well, a couple of out-of-hours services. And we started this program of work back in 2003. And I do a few of these talks every year. And people ask me, you know, what's the best advice you can give if I'm starting out an interoperability program at the present time? And I have to say that the best advice I can give is start 15 years ago, because there's an enormous amount of work to do and an enormous number of organisations to kind of pull together. So for the first few years, probably about the first half of the time that we've been developing the system, we were called the Hampshire Health Record, and really we were concentrating on those sort of dark blue blobs, which are getting data into the product so that people could access it, and when they got there could have a reasonable expectation that they'd find information about the patient in a kind of if you build it, they will come kind of way. And then more or less the time that I was starting to come onto the program, we started to concentrate on something that we call single sign-on. I'm going to come back to that in a second. And that's those purple blobs in the middle part of your screen. And then a couple of years ago, we also moved away from just being Hampshire focused. We went over to the Isle of Wight, and in doing so we also changed our name, because if you go over to the Isle of Wight with something called Hampshire, they don't let you leave. So we changed our name to the Care and Health Information Exchange. But as well as just sort of dropping the Hampshire bit of our name, that was also an indication that we had ambitions to be more than just a record, and this is an exchange of information between professionals. And we've also expanded out from health, and we now cover social care information as well as care homes. So if we can go on to the next slide. So I said to you a moment ago that that I'd talk a bit about this thing called single sign-on. About over 90% of our users come in now using single sign-on, and the front-end access to the system is variable. So on the left-hand side here, you can see what this product looks like in Hampshire hospitals. So it's Basingstoke and Winchester. That's their electronic patient record on the left-hand side, and you'll see that there's just a drop-down menu, and one of the options, as well as pharmacy and ordering and forms and stuff like that is CHI access, and a user will just click that that button, and they'll be through into the shared care record. They don't need another to remember a username and password. They pass through from their line of business system directly into CHI, in the context of themselves as a user, as a doctor, and also in the context of the patient that they're looking at. So that's obviously that's done in a secure and auditable way. But it's obviously very easy from a user perspective, and that's easy because, and that's important because it drives usage. So as I say, when I started this, we had just implemented this in Southampton, and if we can go on to the next slide, we were seeing about 3,000 patients being accessed, mainly at Southampton. And to give you some sort of context, 3,000 is enough to fill a football stadium. In fact, it's enough to fill this football stadium, which is Lewes in East Sussex. This is a grudge match against Eastbourne. And if you gathered together all of the patients that that had their record accessed in CHI back in 2015, we'd have filled this stadium, and we were pretty pleased with that. 3,000 patients a month seemed like a lot. Fast forward 5 years, we go on to the next slide, you would need a bigger stadium. In fact, you'd need this stadium. This is Salt Lake Stadium in West Bengal. It's the home of the Indian national football team. It seats 85,000, and 85,000 is the number of patients' lives that we touched last month, August in 2020. And we still see that rising. We don't think we've got access nailed as yet. But we do think that we are now the go-to place for information. And if you think back to Doris's story, we think that's really important, because having a go-to place which everybody who's involved in a patient's care across separate organisations, against disparate organisations, and involved in different disciplines, that's really important for the continuity of care of somebody like Doris. That everyone's on a page with what's with what has happened to her in the past, and therefore what needs to happen to her in the future. Okay, so if we go on to the next slide. So we're not, obviously, we're not in the business of sitting on our laurels. We think we've done a reasonable job so far, but we think that there's an enormous amount that we still want to do. We're part of the Wessex Care Records LICRA, and under that programme, we've got quite an ambitious programme of work for the next period. I just want to pick out a couple of these things. So a lot of it is continuing to improve the access to data for different professional groups and improve the data that we hold. But one of the things we're really keen to do, based on some of the feedback that we've had from our users, is that we want to get away from just being a record of what has happened towards being a planning tool for what is potentially going to happen to our patients in the future. And I know that Joss and Michael in a moment are going to talk more about that, so I'm going to leave that there. But one of the things that we're very keen to do is develop our care plan facility. And also one of the other things is that bullet in the middle there is population health management. So what Shauna was talking about a moment ago, which is using the knowledge, using the information that we hold about our patients and about what's happened to them in the past, to try and make some predictions about what's going to happen to them in the future. So we're involved in providing data into the population health management tool. So that's both at a macro scale to enable systems, health systems, STPs and ICSs to plan care in the future, but also at a sort of individual patient level to be able to identify patients at risk. So patients at risk, for example, like Doris, of developing problems around management of their weight, and be able to target services on those individuals so that we hopefully pick them up before they get to the stage of being really sick. So we think that there's a really exciting future for interoperability. If we can just nip on to the next slide. And just, I'm not going to name check all of these, but obviously in a enterprise of this nature, there are a huge number of organisations who have an interest, and I would like to thank them all for enabling this to be possible. So I'm going to stop there and hand over to Joss, and I look forward to picking up some questions at the end.
Thank you, Peter. That's great. So hopefully everybody's got from what Peter's talked about that idea of really the time and the evolution of the shared care record. So my name is Joss Palmer, and I'm going to be talking about another shared care record that we support, which is called Connecting Care. But I'll just say to contrast really with Peter's story, I thought that I would really just focus in on some of the projects that we've done over the past couple of months to support health and care services in our region around COVID, really. So if we go on to the next slide, I'll just give you a little bit of context for the Connecting Care programme. So the programme is based in Bristol, North Somerset and South Gloucestershire, and that's a population of about a million people or so. And it is a really diverse and different region. So whilst there are some pockets that are definitely healthy and wealthy, there's considerable health inequalities, and there are some areas that are quite deprived. And in terms of life expectancy, then that can vary 15 years or so, from one part of our region to the next. And that might be something that's really familiar to some of you who are listening, and that might resonate in terms of places where you live as well. So that's where the Connecting Care programme is based. And if you look at the next slide now, then what you can see there are some of the organisations that are part of the partnership. And so these are all people that we actively work with. And as you can expect, you can see there is our clinical commissioning group. And there are also some hospital trusts, so those are big teaching trusts. We have some out of hours integrated urgent care and GP provision, and mental health, and of course local authorities as well. Perhaps you can also see on the slide there some smaller organisations, including voluntary sector ones, and many of them have more of a niche interest, so perhaps it might be around hospice care or drug and alcohol support or supporting the homeless. So that is a rich mix of organisations, and kind of back to Peter's story on Doris, it is very often the case that for many individuals that their care will touch a number of those. And so hence the importance really of joining up data, joining up information, so that we all become much more centred around that individual. So let's move on to the next slide then. And so absolutely one of the main things that the Connecting Care programme provides is a shared care record. And Peter showed a little sort of screenshot, and I'm sure some of you have seen these types of things before. So you can see there, there's a sort of screenshot of some of the kinds of information that is pulled together from lots of different sources, from lots of different organisations. And in terms of the Connecting Care user base, so there are over sort of 7,000 clinicians and social workers that are using the system, and upwards of 60,000 different patient records or individual records that are used or looked at every month. So that's over 60,000 people whose care is enhanced, hopefully, by the fact that information is being shared. There are some other things that the programme does, as well as the shared care record. So we also support a couple of personal health records, which are the kinds of apps that you and I might use. And we also provide some document delivery to GP practices. So that's a bit of a flavour around shared care records and interoperability within the Connecting Care programme and partnership. And on the next slide, then, I will just tell you about some of the work that we've all been doing over the last few months in supporting the response to COVID. So first off then, I think one of our initial focuses was just to try to make sure that any frontline staff that needed access to Connecting Care had access to Connecting Care. So that was really about ramping up and going out and speaking to all of our partners to find out who needed access. So there's a picture there of Dr. Mike Taylor, who will be coming along and talking next, and he is our clinical lead and is based in the Homeless Health Centre. But it obviously wasn't just Mike and his colleagues that we were offering licences to, it was the whole partnership. And as some of you will know, Bristol was also a Nightingale hospital, which thankfully we didn't have to use, but that was part of our preparation activities around licences. So that was one of the main things we did. Second thing that we did was that we looked to accelerate some kinds of information sharing. So I think a couple of good examples is that one of our hospital trusts were really keen to share the respect plan, the respect information that they had internally, but it wasn't visible to other people. And likewise, our out-of-hours integrated urgent care services wanted to accelerate the sharing of something that they call a post-event message, which is a bit like a discharge summary, really. So we brought that all on really quickly within a matter of weeks, working with some of those organisations in question. The third area then I thought would be interesting to share is care homes, because that's obviously such a huge topic nationally around, well, in any case, but more so even with COVID and the pressures that they've been under. So we started talking to our care homes beforehand anyway, but obviously as they got busier and their priorities shifted, some of our normal engagement wasn't possible, understandably. So what we've been doing is a couple of things, really ramping up access, so really making sure that the care homes had access to Connecting Care, and also we're doing some work with them, and that's continuing on now, about what kinds of information do they really need, and what do they really want to share. So particularly with other organisations that would be involved in care, like primary care or hospitals. So we're focusing quite a lot on how we can improve that care planning between the different sectors and care homes. And then the final example I wanted to share is about bringing into the record the results of analytics and risk scores. So that is, essentially to try to flag up to people using Connecting Care whether or not an individual is at higher risk, around COVID. So there are a couple of things that we did. So one was that we shared the Nhs Digital Code, and probably some of you are aware of that was a code that's kind of went into primary care, but it wasn't necessarily visible to other people. So that's now visible in Connecting Care. And the other is that we had some clinical leads within our CCG who did some work looking at analysing the risk that people faced based on comorbidities, and that's something called the Charleston Comorbidity Index. And they did that analytics, and then that risk score, if you like, is now shared within the Connecting Care record. So those two things were a first for us. So they were a first because we hadn't before incorporated into the shared care record that kind of results of analytics, if you like. And I think that really speaks to what Peter was talking to around population health management and the move to how shared care records can become more of a planning tool for future care. But it was also a first for us in that we delivered it in a matter of days. So it really was very fast delivery for us, and that was because understandably we recognise the importance of supporting frontline staff around COVID and the care that they were providing. So hopefully that's an interest, just kind of like 4 areas where we really focused our effort on in the last couple of months. Particularly responding to the partner organisations and what they needed to have happen to support them with COVID. So I am going to hand over now to Mike, and Mike is a GP and he is the lead in the Homeless Health Centre, and Mike has been so inspirational and so supportive to the Connecting Care programme, and I think here Mike is really just going to talk a bit generally about some of his experiences and why this really matters. So Mike, over to you.
Well, thank you very much, Joss. If I could just have the first slide, please. Okay, so this is me before the days of Connecting Care, screaming silently about the lack of information. Connecting Care really started in 2013, so it's quite a while ago, but immense frustration about not being able to see people's records and the necessary information. Next slide. So I think the best metaphor, the best picture for this is a jigsaw puzzle. I find it easier to think in pictures than words, really. And being able to see patient data is like putting a jigsaw puzzle together. But in this world, you don't only have a rough idea how many pieces there are, and you don't know their shape or quite how they fit together. So you've got to work that out. And you haven't got a nice picture on the box of the jigsaw puzzle, which tells you what it's meant to look like at the end. So, you know, there might be 1,000 pieces. You've got no idea what the picture's supposed to be. And it would be wrong to make assumptions about the picture that you're going to get. So you don't know how many pieces, you don't know how they fit together, and you don't know what the final picture is. You have a rough idea because obviously, patients are fairly similar in some respects. You have a rough idea, but the first big mistake is to think that you know all about it. You know everything there is to know about the patient. So my first rule is don't make any assumptions, or put it another way, you don't know what you don't know. And often it was said in the past that ignorance is bliss. Well, in the new world, ignorance is not bliss. In fact, ignorance is negligence. Anyway, for the purpose of this brief presentation, I'm going to talk you through what I do for every new patient in the homeless service every time. So whenever there's a new patient, and in fact, for a lot of patients I don't know very well, I just have to go through this because I don't know what I don't know. And I do know that I really need to know it. So I set about this jigsaw puzzle, and in this case, I'm going to talk about a patient called Sarah. Let's call her Sarah, that's not a real name, who attended the Homeless Health Service having come up from Cornwall via Horfield Prison for a while. And this was a few weeks after her release from Horfield Prison in Bristol. So Sarah was attending to ask for repeat medication and a sick note. So how could I maximize the potential of this consultation? We have a bit longer than normal general practice, which is only 10 minutes. In fact, we just take as long as it takes in the homeless service to do a good consultation. So trying to maximize the potential. Next slide, please. So, sorry, on that first slide, but keep it as it is, the HHS EMIS is the basic EMIS program in which we start, where we register patients and we can find out, we go from there. So this is step one, is to get them onto the EMIS system and synchronize their records with the spine, so at least we know their NHS number. and we can search. I can search for them on Connecting Care. So the second piece, and I can see that in my slide here, some of the text isn't showing fully, but that says Connecting Care. And I go there straight away to see if there's been any recent activity showing in the hospitals, in other general practices, and are there any special risks? What is known about them? And there is an awful lot that presents in the dashboard of Connecting Care to give me that basic information about their health and social care. So in Sarah's case, she'd only been here a few weeks in Bristol, and there were a few ED attendances, and I could confirm her demographics and confirm that she hadn't registered in any other surgery. So the next slide, please. So what I always do, especially when people have come from out of area, is look on the spine, having synchronized the patient with the spine. I can look on the spine then to look at the summary care record. Now, so in recent months, in the last year or so, the summary care record, the advanced bit of the summary care record has improved things greatly. In the past, we only got the registered surgery, the basic demographics, and the medications that people had been on. And that was very useful if people were coming from London or Edinburgh or somewhere. Actually, I shouldn't have said Edinburgh because they're outside in the UK. They're in a separate country, aren't they? We're talking about England, really, with the summary care record. So I could see who their GP was, what medications they'd had very recently. And that was about it. But with the advanced summary care record, and that's been made available much more since the pandemic, it is possible to see basically everything that we get in Connecting Care. So in Connecting Care, we have the MIG data, which is basically everything that's in EMIS presented. And in some, when you're very lucky with the summary care record, you get something a bit similar. So that has helped with patients who are coming in from out of area, which is quite common in homeless health because people move around tremendously. So next slide, please. So I'm already going to be asking you, you think you know what the picture is going to be, and just hold that in your mind. So this is called Theseus, this next piece of the jigsaw. And if patients are asking for opiate substitution therapy, which Sarah was, it's very important for me to know whether they have left prison with a prescription for methadone or buprenorphine or something like that, because of their heroin addiction. And Theseus is the local system in Bristol, which gets all the substance misuse information into one place and sends reports to the Home Office from the system and is used by shared care workers in practices. Now, one of the success of 2 or 3 years ago now was to get information about prescribing into Connecting Care because of the danger of duplicate prescribing. Where patients go to one surgery after another to try to get additional doses of methadone, which has a street value and is potentially very dangerous for them in overdose. So we got the basic information out of Theseus and presented in Connecting Care, which is extremely valuable. But being an enthusiast, I've also got a Theseus login, so I'm able to check whether they've all the consultations they've had with shared care workers in the past, and the after prison prescribing service and what's been going on there. So already I'm beginning to make the picture richer. I'm knowing much more about Sarah, that she's had some prescribing from the after prison prescribing service. And I needn't give her that, and I needn't be conned into thinking that she really needs that, which was a disappointment to her, I remember, but nevertheless, an accident prevented. So if we can have the next slide. So AWP Rio, well, in homeless health, 70% of people have substance misuse and mental health problems. So I need to see as much as I can about their mental health. And luckily, you know, we have been able to get certain aspects of the care plan from Rio, from the mental health world, interconnecting care. The crisis plan, for instance, very valuable, especially if you're looking at it from ED, and very valuable to me. But as I said, as an enthusiast, I like to log into the real system as well and see exactly what patients have been saying to their consultants and psychiatric workers. So again, it's having the information so we can maximize the potential of the consultation with all the mental health information. Absolutely invaluable. And we're hoping to get more and more of that into Connecting Care as time goes on. So I was able to learn from this that Sarah has a considerable past history, as I've said, with so many homeless people, a long history of childhood abuse, a long history of domestic violence, and a long history of subsequent personality disorder problems, and we're already into a very rich, data-rich picture of Sarah and about the sort of care we'd be able to offer. So the next slide, please. And so again, we need to know what outreach, what the homeless outreach teams have been doing for Sarah, and what the council, what the homeless support record, I've forgotten what HSR is, the housing support register, I think. That's it, housing support register. So firstly, the St Mungo's Opal system, it tells me who's been working with her on the street and what are the plans have been. We have enabled them to look at some aspects of Connecting Care where it's going to help them to know what medicines the person's been on, with consent, of course, and how many times they've been to ED. So that's been really good. So looking at the outreach workers' notes and also at the housing support register notes to see where Sarah is on the housing pathways and where she's stayed in the last few weeks since leaving prison. So having got that information, I then have a much better picture. I can go back to Connecting Care and look at more targeted things, look at her all her any results and x-rays that she's had, look at this, what social care information we have on that system, and crucially be able to see how many ED attendants she's had and what future appointments are coming up. So useful to be able to see that she's already got an appointment with the hepatitis clinic. She's already got an x-ray booked for her bad chest. Just to confirm who's been working with her over the few weeks the care around the patient, who's been working with her since she left prison. So you might have, if you had none of this information, Sarah would have been, there would be no colour on the picture, there'd be no pieces connected together, and within a very short space of time, within a few minutes really, I can have a much better consultation with Sarah. So for those of you who've made assumptions about the picture, if we could have the next slide, please. So there she is, Mona Lisa, enjoying a spliff, and you know, it fills out with a little cannabis plant in the background, and it tells us that things are never quite what they seem, even if Leonardo da Vinci thought otherwise. And then the next slide, please. Which enables me to try and improve things for her, to try and put a smile back on her face, to work with her to get her life a little bit more sorted out. And the final slide, and that means that I'm much happier with Connecting Care than I was without it. So the screen has been replaced by a thumbs up and a broad smile. So thank you very much. That's my experience of the jigsaw puzzle.
So thank you so much, Mike, particularly for keeping it real and letting us have a bit of insight into the world that you actually have to work in every single day. That's so interesting. in SCW, we're working all the time to support people on the front line, and it does make what we do worthwhile when we can hear how you can actually help people on the ground. So thanks very much for that. We've had some questions that have been coming in, so thank you very much for those. And the first one I'm going to ask to Joss. We've had a couple of questions about connecting care. Are there plans to extend the geography of that Bristol, South Gloucester, North Somerset interoperability programme? And also, could you also tell us how the Gloucester DEWI programme fits into the SCW family? Thanks, Joss.
Of course, yes. So I guess probably the overview is to say that across the country, as Peter and I have perhaps talked to and illustrated, different regions have got shared co-records at differing sort of levels of maturity, and in many ways what that does is it reflects a sort of natural geography or areas where there are natural patient flows, if you like. So where people, for example, would refer to a specific hospital or hospitals, and you often will see shared care records sort of coalescing around a pre-existing geographical collaboration. So I guess in terms of the DEWI, which for those of you who don't know, that's a Gloucestershire shared care record, and that's been up and running for quite a while now. So it doesn't link to the Connecting Care record in any way yet, but I saw there were some questions there with Lakers, so probably Peter will talk to that in a second. But that's very doable technically, and there are certainly some sort of flows between sort of the Gloucestershire region and the sort of Bristol region. So that's very definitely work that is possible to do. And there are, of course, some colleagues in SCW who also work and support the Gloucestershire health and care community. So, you know, we've kind of like historically kept in touch and just shared news and so on. So that's sort of covering the Gloucestershire side of things. And I think there was another question you said, Fran, around expanding connecting care. So probably some of the listeners will be aware of some of the regional sharing endeavours or LACERs, and I would very much envisage that a programme like Connecting Care would be part of any sort of much wider regional LACER, and that we would need to contribute towards that in some way. But equally, I think there are as far as I know, there are no obstacles to any sort of to other people joining the Connecting Care programme if they would wish to. So that's probably in a nutshell. I know it's probably a little bit quick, but hopefully that's a good enough answer.
Thanks, Joss. And we've actually had another question is about whether there is a way to find out about all the systems that are available under the SCW umbrella. So I think that is something that we've been working on together. In fact, we just were a finalist in the HSJ Awards under the SCW umbrella, bringing forward all the work that we're doing through all our programs. We've got quite a number of those running. So Peter, I wonder if you might just talk about, obviously, the one that you run, the CHI program, something about the Wessex programme also would be useful. We've had a specific question around CHI about one medication record, but I think as the umbrella that hopefully will be bringing all these things together, if you wouldn't mind talking a little bit about the LACER or the LICRA and just giving a bit of background on that for people, that would be really helpful.
Yes, thanks, Fran. I also wish we could decide what we're actually calling this thing. In our area, it's called Wessex Care Records, and it is records. So we are a joint endeavour alongside Dorset Care Record, which is the other Interop, our sort of partner in the Wessex Care Records programme. I think there've been a couple of questions about that. So one of the things that we've been very keen to do along with Dorset is to sort of pilot how we pass information between ourselves, between the two Interop programs, with regard to patients who cross those borders. So we have a significant amount of our geography which would naturally look towards Bournemouth and Poole as their acute centre. So basically the sort of the western side of the New Forest area. So it's really important for those patients that when they travel out of area for treatment, that they get the same experience as they would do if they came to one of the Hampshire acute trusts, Southampton or Winchester or wherever. So we've been working with Dorset on that. In terms of the sort of one medication experience that we've had a question about, so that is one of the things that we are working with Wessex Care Records on. We hold now, and we've held for quite a while, GP prescribing. And that's good, but we do recognise that it is not the complete picture when it comes to prescribing in its totality. So we have now been commissioned by our local ICS to start to have to build up that picture. So we'll be still talking to our acute trusts, to our mental health trusts, and other specialist providers around ensuring that we have a more complete picture of prescribing for a patient. And I think Michael earlier was describing some of the really important ways in which an incomplete knowledge of prescribing can be really serious. And I think back during my own career, we had a very unfortunate case when I was working in Bedford of a young woman who sadly died as a result of inappropriate prescribing of methadone. We do recognise that that's a really important element, and we are at the moment showing a part of the picture, an important part of the picture, but definitely only a part.
Thank you, Peter. So Mike, can I just come back to you as you've just had a name check there, and ask you another question that we've had, which is about what you would like to be the next big step forward in this area.
Okay, well, I think the answer to that is very clear to me, and it was clear to other CCIOs in various parts of the digital world here in Bristol, that what we all want is access to care plans which are fully synchronized across different organizations and departments in real time, so that we have, for instance, take the end of life care plan. We need all sorts of people to be able to read it and comment on it, keep it up to date, and have no muddles about which is the master copy and who's looking after it, and all the things that can go wrong when you have it all split up and dependent on several different processes happening at the same time. And I think we're still in the dark ages when it comes to synchronized documents, care plans. The travel industry and the banks managed to do these things, but we haven't quite sorted it out in health and social care. So, I would love to be able to see an end of life plan which was shared and in which the patient was involved. It's so important with these plans to include the patient and include their and respect their decisions and respect their views and have it properly represented in their plan. For something as crucial as dying. So that would be my main wish, and for me it would be also the high impact user of the accident and emergency departments. How can we really synchronize all the good things that are going on around a patient so that we all know about them, and have the patient be able to read and comment on those things as well. You know, so yeah, I think we're really far away from that.
But two extremely important points there, which is about the empowerment of the person, and also getting real-time information around plans and other sorts of data which forms documents. So I think we've come a long way with sharing of records, but actually what's in those records is the next big thing. We've just got 5 minutes left. There has been a question in about role-based access. So obviously this is touching on information governance. So I don't know, Joss, if you would like to just in a couple of minutes talk about the role of information governance and how role-based access is used to make sure that only people who need to see information that's required to do their job can view it.
Yeah, of course. So absolutely, and I think probably common across any shared care record will be the concept that people have different roles which relate to the job that they do, and that information will be tailored to those roles. Some of you may be aware that at a national level, with some of the discussions around the regional LACAs, that they have sort of talked about and considered role-based access. I think probably within Connecting Care, we have slightly too complicated, we've got slightly too many different roles, and so we're looking to simplify that. But the basic gist is that roles relate to the work people do, the information they need to see, and that people see the information that is appropriate for them and their roles. And that will be the case pretty much on every shared care record. And normally what happens as well is that other features that are important for information governance, like audit, will be tracked to that, so that you can then, if you need to, see what an individual user has been looking at and what they've been doing within the systems.
So that means that the data is very well protected, and information governance is fully in place. So thank you for that, Joss. So we have had a couple of questions which we haven't had time to get to during this live session, but rest assured we will address those, and they'll be published out later. So I would just like to give a really big thank you to our marvellous presenters this afternoon, to Shauna, to Peter, to Joss, and to Mike, and thank you everybody that's been in our audience today. Please, before you go, could you leave a quick comment on the Q&A on the right about how you found this event? We are going to have an on-demand recording of the video of the event available shortly, and also you can continue this very interesting conversation on Twitter using the hashtag SCW Digital. And so from all of us here at this live event today, on behalf of SCW, thank you very much and have a good week. Don't forget the other sessions during the week. Bye for now.
Bye.